US perspective, and then we have an Indian perspective to this.
Thank you very much. First, let me say there are as many answers to this question as there are questions to this answer. So I will proceed with it from that. So this is the child that's coming in, and you can see it's a pretty badly displaced supracondylar fracture, and with a pucker sign, so all the potential for badness is there when we see this. And it's a posterior lateral displacement, which causes much more arterial injury and damage than any others. So what do? This child deserves an urgent closure reduction and percutaneous pinning, but it depends on the outcome of the reduction as to whether or not there's a pulse there. If you have to transfer in a patient like this, you can apply a splint and send it on if you don't have the facilities available at your hospital to go directly on, because we would recommend that you go directly on with it. The Milken maneuver, grasping the brachioradialis, or brachialis, and then milking it down is important to do, and it's an important procedure to learn. How effective and functional, I don't know, but I think everyone should do it. And again, that's another one of the answers that maybe the question's not there. The intrafocal K-wire pinning, that's a technique. It's a different, I can't say that I have a lot of experience with it because we've mostly done the manipulation, but it is pretty much of a new wave. It's done. Again, I wonder about some of the things that the pin involves an injured, potentially injured when you do this. Nevertheless, I'm going to give 3 scenarios, and they're going to be quick. 1, closure reduction percutaneous. This is the same child. Percutaneous pinning. The hand is pink, perfused. The pulses are now palpable. What do? And the answer is, you're good. You're good. Everything is good. So that's question number 1. And you can follow this child and see what happens, and you have a good result, and all is good. Number 2, closure reduction, percutaneous pinning, and now the hand is pale. The pulse is not palpable. So then what do you do with that? Well, what do you do with that? You operate as soon as possible because you would like to have the hand to be no worse than it was when you started the intervention. And in this particular case, this one was easy because there was an absence of the pulse, and it was pretty obvious why I was there. The hand surgeon came in, a direct repair was done, and the child did very, very well. Now, the last one. The hand is pink, it's perfused, there's good capillary reflex, but the pulses are not palpable. What do? And this is where convention, where reality and everything sort of clashes, because this is the controversy. And I must admit that I am guilty of being a part of the controversy that's pretty much gone worldwide as to whether or not there is injury. There has to be injury. What is the injury? How significant is it? And here is a child. Let's say that we would play this as closure reduction, radial pulse maintained, but it's absent of palpation. The hand was pink and warm. What happens with this patient? Well, this is where one of the cases, and this is a Melman case, where he went in and found out that the brachial artery was disrupted, even though everything was considered to be good on the distal segment. What are the problems that's associated with this? When the brachial artery is not there, but there's quote-unquote good perfusion, well, there is a good collateral circulation. Here you have the brachial artery that's blocked, but then you have the collaterals that come along and can give you a good hand. However, the collaterals are good at keeping the hand perfused. However, they're not as good for keeping the deep volar compartment. And so there can be deep volar compartment injury and contractures that have been reported as a result of this. So then to look at it. There's no guarantee that the collateral network is robust. The variant upper extremity arterial branching occurs in about 20% of limbs. And so this is where it had been recommended that the duplex scan be done. And that is that you go and explore, you have the hand service there in case you need to do a vessel repair or whatever is necessary. But there are difficulties with carrying out this mission. When we look at the series that are there, the pinkless pulseless hand should undergo a color-coded Doppler suplex, and whether or not that's real or not. 2 articles have come about, 3 articles now since the initial article. But there's a persisting and increasing pain suggests ischemia, and vascular exploration with fasciotomy was recommended in the patients that they reviewed. Now, so what about this paper? What about this talk? These comparisons highlight the discrepancy between available evidence and popular opinion. Due to inherent selection bias of the original studies, our analysis was limited to descriptive statistics. The methodology quality of orthopedic meta-analysis has increased over the past 20 years and continues to. More stringent protocols. So, does the absence of evidence reflect to the evidence being absent? And that's the question. So with that, I'll present it to all, and I think we can have some discussions about that. Thank you very much.